Saharah.
Hey.
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 Good morning.
Hey, how are you?
Good.
Great to
Happy
see
Monday.
you.
Yeah, good
I
to
know,
see you too.
I'm going to troubleshoot a couple things. I just want to make sure that we're also on Facebook.
Good.
So if you'll give me just one moment.
Yeah, sure. You're fine.
Supposed to be somewhere where I can see share in group. I don't see that though. If you hop over to OCD Texas Facebook page, do you see us on there? Oh, wait.
Let me take a look.
Share in group. I see share in group. And then I get to put the name in there. It says to share the event name in there, but it's not letting me put the title, so I'm not really sure what to put as the group name.
Huh. You just do the less frequently discussed.
I tried that and it's not letting me.
Okay.
Share in group. OCD Texas, no.
Okay, so I'm looking at the place where it's advertised.
Let me go back here and see again. Live on Facebook. Which, by the way, I think all this is recording, so yay.
Okay, sounds good. I'll make sure not to swear or et cetera, et cetera. Oh my goodness. You wouldn't believe what happened this weekend. It was insane. No, anyway.
Yeah.
Yeah, the insanity of my weekend is only related to toddlerdom.
I'm going to call Ivy really quickly and ask what she did. Which, by the way, I think we already have someone in there waiting to join, so I'll let her wait for a little bit until we get started.
Great.
Hi, it's me.
Hey, hi.
Okay, so I'm on the go live on Facebook and share in group. It says to put the group name. What am I supposed to put there? It won't let me put the presentation title.
Group name?
And that's what it says on Melissa's directions too.
I remember I changed the title.
In Facebook, it says go live on Facebook, click share in group. It says type in OCD Texas. I'm typing in OCD Texas, but it's not accepting that.
I can't remember. I feel like it was just a drop down and it gave me the option of doing OCD Texas.
That's not coming up for me.
I feel like it was a drop down. I don't know.
It is a drop down. Okay. But
let's see. I remember the only thing that didn't work was that I hadn't put a name on it, so it didn't actually work until I figured it out. So I don't think I was looking at Melissa's.
Share on a page you manage, OCD Texas. I can do that, but I can't do share in group.
That's what I did.
Okay.
Yeah.
That's very different.
Yeah, that's what I did. That makes sense.
Okay.
I don't know what group is, because it's not a group, it's a page.
Yeah, so we should let other people know that it's not group, it's page.
Yeah.
All right.
I didn't even look at Melissa's instructions, so, okay.
Okay, thanks.
Good luck!
Thank you. Okay, so I think we are going live on Facebook.
Okay.
Follow the prompts. Next. Choose how you want to start setting up your live video. Use stream key, use camera, or use paired encoder. That I don't know.
Beyond me.
I'm gonna just keep what it's on. Okay, we're gonna do that. And click record to cloud. I am not going to be looking at Facebook because I don't know what that is doing there. I'm hoping it's capturing everything it needs. Okay, it's recording in Zoom at least. And hopefully someone will edit out all this pre-stuff.
And if not, oh well, they just get to know us by personality a little more.
Yeah, okay. So I'm gonna keep it where I can see people who are trying to come in, so I can just click on them. We should be able to see.
Y'all are live in the webinar and look great. Well, thank you.
They can see us.
Well,
great.
Quite a compliment for Monday morning. I love it.
I thought I had to let people in. So we're gonna wait a few minutes to get started, just since it's not 12 yet. But I'm so glad everyone got to hear me being super inefficient at doing all of this.
I'm just really grateful. You're taking care of it. There's so many nuances between the different platforms. So I
well, yeah,
appreciate your work
and they
with
were,
that.
yeah. So we'll make it work, and hopefully
Yeah.
everyone will be patient with us if we're struggling with that.
Yes.
I think I am. Yeah. I think so. Okay. So we'll wait a couple minutes. So, oh, we have a couple of people. Yay! I'm losing stuff here.
All right.
So if you guys have made it here, I'm guessing it wasn't by accident. This is the less frequently discussed subtypes of OCD for OCD Texas. We're gonna wait just a few more minutes, see if we have any other people joining us since it's not quite 12 yet. And then we'll get going in just a minute.
Saharah, I did not realize this until a couple days ago that you were trained in the Bergen model. That is awesome.
Yes. Yeah. So I was still at the Houston OCD program. We were going through all of that. And so that was a very interesting experience. I think I think once you go through it, like, you realize it's quite natural to what it is that we already do. There are definitely some key differences that push us out of our comfort zone. But yeah, since I've left the program, I'm not sure what's going on with all of that. I know that they're not going any further with the Bergen model there at the program, but I'm curious what's happening worldwide with all of it.
I am too. Yeah, and the research, and if other places have started, it's really interesting. I'll have to talk to you more about that separately.
Yeah, absolutely. Yeah, that was a fun experience. I'll see memories pop up on Facebook of what we were doing at certain times, just as the providers who were running some of those groups. I'm like, oh, like this time last year when there was a flood, we were all stuck there when we couldn't go out into the community to do all of our exposures, and making the most of that.
Interesting. Yeah, it's always interesting when you have those remembrances of different things, like a flood, or actually when my daughter was born, it was a hurricane around that time. So we joked about naming her after the hurricane, but she's actually a fairly chill child. So that
infants are a hurricane in a very different way.
That's right.
Or can be.
That's right.
But yeah, so it was interesting. We had people that, like, when you do it, like, you do it one-on-one with one of the participants. And so we had people all around Houston, like someone at a mall, someone, I don't know where they were, but it was just like, so people were stranded. We had someone stuck on a freeway in the car with a participant. Like, it was just, yeah, it was an experience.
Wow. Gotcha.
Definitely.
Yes. It could be good for this. Also, it could be difficult if a person was doing a driving exposure at that point to have that. But
so I actually was doing driving exposures with someone, and we luckily were able to, like, get back before we weren't able to drive anymore. But that was one of those, like, really good opportunities to lean in, because it was obviously torrential raining. But it was fun. So, Well, it looks like we are right at 12 now. We maybe don't keep our attendees waiting much longer. And Justin, do you want to start us off? Do you want me to take the lead?
Yeah, I can start with just a quick introduction and then pass it back to you as far as who we are.
Perfect.
So first of all, thank you so much for being here today. This is a discussion. Let me say that up front. So we are looking for your questions. We're here to discuss, really share our experience in the realm of treating OCD. So Justin Hughes, first of all, I'm up here in Dallas. I'm in my office in far north Dallas right now. And I specialize in CBT and exposure therapy for OCD, anxiety disorders, and such, a lot of connected things. We'll talk about that actually quite a bit here today. But I would say about 90% of the people that I see have OCD. It is my main clinical passion, love it. The reason that I got into it in the first place is that I just truly have, if I can say fallen in love with, don't mean it in the sense of with my wife, but fallen in love with those who suffer. It's a very awesome population of people, and just so grateful to do this work every single day. It's absolutely incredible. So that's just a little bit about me.
Absolutely. Yes. And I'm Saharah Shrout. I'm also a therapist that specializes in treating OCD and related disorders. Similar to Justin, the large majority of the people that I'm working with either have an OCD diagnosis or something in the OCD family or some other anxiety disorder. So I specialize in cognitive behavioral therapy, really that gold standard being exposure and response prevention, which we're going to go into a little bit more detail in just a bit. But I'm out here in Cypress, Texas, which is just northwest of the greater Houston area in private practice. So I've been involved with OCD Texas as well. Justin will talk a little bit more about OCD Texas and Iocdf for some years now, and just love to be able to be a part of events like this, just to be able to increase awareness and really be able to educate people about what OCD is and what it's not. So thank you everyone who's taken some time out of your schedule to join us. Like Justin said, this is a community discussion. So we really are looking forward to hearing what questions you have, just so we can really engage with you all. Yeah. So send us your questions.
Send them in. Briefly on OCD Texas, let me start with what is the Iocdf. So you may be familiar if you've stumbled upon this information or know about this, this webinar here today anyway, but Iocdf, the International OCD Foundation, it's basically the premier group for advocacy of those who suffer with OCD and related disorders. So absolutely incredible to be a part of. I'm not saying this in a hyperbolic way. It was life-changing for me when I started to get involved with the Iocdf back in 2016 only, so 4 years. I had heard of them years prior, had done a number of things along the way, but it wasn't until I really got invested in regularly going to all of the conferences, doing trainings, advocacy, et cetera, that so much was really launched in my own life, personally, and then even from a professional standpoint. So great place to check out, iocdf.org. And so as a subset of the Iocdf, every state, or depending on the size of the city or location, locale, there are local affiliates. And so OCD Texas is one of those. We have a lot of land to cover and a lot of people. I think, what, 40 million people in Texas? Something like that.
Your guess is as good as mine on that one. I can ask Google if we want.
Yeah, so when we break it down, and the best research seems to indicate about 1% to 2% occurrence with OCD in the population. So when you think about that, I mean, 1 to 2 out of 100, outside of the pandemic, if you walked into a normal restaurant, there would be at least one person. So even though sometimes people think, oh, 1% is rare, when we actually break it down day to day, there are folks all around us. So anyway, OCD Texas, the official affiliates, and this whole week, there's programming. Check out Facebook, Instagram, however you discovered us for more information. A lot of great talks to be a part of, discussions, stories, personal, everything from athletes to professionals to sufferers, etc. So that's a little bit about the IOCDF and also OCD Texas.
Excellent, excellent. And something to be aware of, next week is OCD Awareness Week. And so a lot of events will be going on, not just with OCD Texas, but the International OCD Foundation. This week, OCD Texas, like most things, we're doing it virtually. So we have to sort of flex with the times. And so this week, OCD Texas will have several live presentations and community discussions going on, something going on every day. So that'll be a really great opportunity for you guys to get involved, and for professionals, get some CEUs, for individuals or loved ones, just to be able to learn a bit more about OCD and different variations and treatment approaches and things of that nature. So a lot going on this week. We encourage you to continue to tune in to OCD Texas the rest of the week. It actually be capped off, I wanted to make sure to mention as well, to be capped off Saturday, at least OCD Texas's participation will be capped off Saturday with the 1 million steps for OCD walk. Again, a virtual walk, so people in your own community, if you haven't registered, there's still time to register, to just do a walk in your area to build awareness, to work on really breaking through the stigma associated not just with OCD, but mental illness in general. So, so that's a little bit about us, OCD Texas, and the IOCDF. Now I think we're gonna touch base a little bit more about what is OCD. And so many of you who are joining us probably have some information, basic understanding of what OCD is, but I usually like to be able to start just by sort of differentiating the two components of OCD, the obsessions versus the compulsions, just so we have a good baseline or foundational sort of frame of reference of what we're talking about when we talk about obsessions versus compulsions. And so the obsessions are generally going to be intrusive, unwanted. They're often disturbing, maybe thoughts, images, or impulses that individuals experience. The general population experiences intrusive thoughts, but for those people with OCD, these are going to be repetitive, recurrent, and really start to get to the point where they're disrupting daily functioning in many situations. And then the compulsions are the responses to those obsessions. So that could be in an effort to neutralize anxiety, to counteract maybe a feared consequence from happening. Compulsions aren't just behavioral or overt overt behaviors that you might see. Oftentimes there's mental rituals or compulsions that are going on. So it could be mentally reassuring oneself, mentally rationalizing, reviewing events as like a mental checking. They could be reassuring oneself. I think I mentioned that already, but there's many different mental rituals that can happen. Just because you don't see or engage in a behavior doesn't mean that there aren't compulsions that are going on there. With OCD, we want to see those two components. There's the intrusive thought, obsession, and then the response to try to neutralize it. But with OCD, the insight can wax and wane. It can vary from person to person, even from day to day. But generally, there is some awareness that maybe these thoughts or responses aren't completely logical or rational, but they just feel like I have to do it just in case, or just because, or it just feels too overwhelming. And so what we'll talk about today are some of the less frequently discussed subtypes. You know, we learn and we know a lot about contamination OCD, or maybe even some of the harm with hit and run OCD. We even hear, you know, a lot of people, maybe well-intentioned, not meaning to make punchlines or jokes about OCD, but as many of us know, it's not a quirky thing. It's not funny. A lot of people are really suffering. And so we really wanted to highlight some of those less known, less frequently discussed aspects of OCD.
Excellent summary. Wow. That was really good.
Thank you.
I'm going to jump into the treatments here just as a brief overview. So again, you may have some general idea if you've ended up here today about the treatment or treatments for OCD. Just a brief overview. So first and foremost, from the medication realm, the serotonergic medications are considered the first line treatment. So you have one SRI, which is clomipramine, but the rest are SSRI medications. And what that means is generally, unless if there's a rationale to do something otherwise, a first line treatment medication wise is going to be one of those medications. So the benefits are significant. The average population might get about 40 to 60% symptom reduction But at the same time, there are those who don't, or it's more complex, or could have side effects, etc. But there's also a lot of different things such as adjunct medications that can be added on, where you may have an atypical medication like Risperdal, etc., or Abilify. But anyway, that's getting way too into that. The main, what we call the gold standard treatment for OCD is CBT, and specifically a subset of CBT known as ERP. So we're talking about cognitive behavioral therapy and exposure and response prevention. What is it? Well, based on the diagnosis of OCD, so Saharah just shared excellently, there are these unwanted, intrusive thoughts, urges, impulses that a person has, and then attempts to find relief with it. And so the therapy, really, when we understand what the problem is, the therapy is pretty easy to understand as well, because the main role and goal is to not give credits to the content of those obsessions and to the behaviors, to the avoidances, anything that actually maintains the disorder. So just for example, in just normative functioning, human functioning, fear serves a very useful role. But if we have this alarm system that's going off too much, so for example, with my 3-year-old daughter, I've had moments where I know that she's okay, but I'm having thoughts or worries or fears in the moment, and having urges and impulses to check safety, well-being. Well, OCD is a disorder that makes it so much more difficult to say no or to write off those intrusions. It's felt so much more intensely and causes oftentimes a lot of disability. And so the therapy has to be powerful enough to train people in changing their responses and what they do. So can't necessarily control an initial quick thought that we have, intrusive thought or a feeling or urge or impulse that comes up, but we certainly can learn over time to change our responses, and that's the piece that tends to really reinforce the disorder. Also, just as of note, ERP is the gold standard, but a first-line treatment for OCD, if there's a reason maybe not to do exposure, or if a person's just totally unwilling to do it, there is cognitive therapy, which really looks at the role of a person's beliefs in OCD. How are their beliefs actually maintaining the obsession and working at it from that side? But generally speaking, without doing a deep dive into why this is the case, the gold standard, our first go-to, unless if we have a really good reason not to, is going to be exposure and response prevention.
Excellent. Yeah, I'm glad you brought up the cognitive component as well, because I think when we get so entrenched in OCD treatment, we automatically think about, well, no, we don't want to engage in all the cognitive component. We don't want to, give it more meaning, but there's definitely can be a place for it. But just finding that fine line of not falling into the trap of creating more sort of rituals like rationalizing or things like that.
That's right.
Particularly if someone is willing to engage in more of the ERP end of things.
Yeah.
So.
Yes, that's right.
So we'd like to open it up to questions if we have any. I've given everyone the ability to speak in Zoom. Not that I have magical powers here or anything, but you should be able to unmute and talk, or if you prefer, you can send us a message. Again, this is a community discussion, so we'd really love to be able to keep this dynamic and organic, just really engage with all of you. If you have any topics you really want to hear us touch base on with regard to some of those less frequently discussed subtypes. So if anyone's wanting to take the first leap. And if not, we can go ahead and start talking a little bit about some of the things that we sort of immediately identify as maybe some of the less common forms.
Yeah, and actually, Saharah, as we're waiting for that first leap is always big to unmute it or send a message either way. Saharah, do you mind just touching base on some of the things that come to your mind when you think of less common, less discussed or talked about themes with OCD?
Yeah, absolutely. Thanks for asking. You know, when we've talked and prepared for this particular discussion, one of the things that I think I stepped into the trap of was automatically pigeonholing it to the taboo versions
Yes.
of OCD,
Me too.
which,
Me too.
but you, I think, very eloquently pointed out that actually those are pretty well covered in terms of, you know, some of the intrusive sexual obsessions and things like that. And so when we put our heads together, we were focusing a bit more on, for instance, maybe some existential OCD. Those can come up as well as maybe emotional contamination or sensory motor OCD. So those are some of the things that we were thinking about being able to touch base on today. And would love to hear if you guys have any sort of feedback or questions about any of those areas. There's definitely a litany of even maybe some of the kind of OC adjacent diagnoses that don't necessarily have their own sort of category or aren't even in the DSM quite yet, but will likely be in the next one. So I think we've really talked a lot more about maybe some sensory motor OCD. Someone might be more familiar with calling that maybe hyper awareness OCD. But for those of you who maybe are less familiar with that, the term is really in reference to individuals who maybe have the selective attention to a particular automatic body response. For them, it feels less that it's automatic and they're just focusing on it. There's this sort of like hyper vigilant focus on this particular body response. It could be maybe blinking or swallowing or breathing. These are things that we take for granted. They just happen automatically, reflexively. But for the individual with OCD who has this particular subset, they're so focused on it, it's hard to not think about it. And in many ways, there's this concern that they're never going to be able to stop thinking about it, and it's just going to drive them crazy. And so there is really like, that's the driving force, or the core kind of fear is, I'm not going to stop thinking about it. This is never going to get off my mind. Other variations of that would be, if I stop thinking about it, maybe that body process won't function as it normally would or should. So I kind of have to keep thinking about it, or I'm not going to be able to breathe normally. Or again, another option or variation would be, because I'm focusing on it and because I'm thinking about it, it's now maybe not, I'm just gonna maybe mute that. It's not functioning as it should. So now my breathing is maybe a little off or disrupted because I'm focusing on it so much. Share with me, Justin, if you feel like I'm missing anything with that.
No, that's, I think, a great overview summary. Again, it can be wide and varied as far as what it is. I mean, the examples, of course, breathing is a common example, but heart rate, swallowing, blinking, any of those processes, interestingly enough, that are automatic or that we can take a certain amount of control over. Obviously, heart rates might have less of a direct control outside of speeding it up or slowing it down over a few moments, but things like blinking, we have maybe a little bit more fault control in the moment. And so coming back to the core fear conceptualization is really significant with this. What is it that the person fears or is concerned about? And so we want to hinge treatment based on that, so we're not just throwing a dart at a random chart, random bullseye, recognizing the actual core fear. Driving that for the person helps us to be more accurate with the treatment.
Absolutely. And I like what you're highlighting there is we want to make sure that there's like that good functional analysis so that we're not missing the mark. No two presentations of OCD are the same. Even if it is, you know, the focus on blinking, for instance, it might really have a different driving force for different people. I think just to sort of have an example, you know, just because it's what we often know about is with contamination OCD, people will have this assumption, for instance, with someone who has contamination concerns that, oh, well, why is your room dirty or things like that. And so for someone with, maybe they do have a clean room, maybe they don't, it just varies. And so we want to really get into what is the function of this particular behavior when you're responding to some of these obsessions. But it looks like we might have a question here. So from one of our panelists, it's saying, what have you found most helpful in treating just right OCD? For instance, feeling dirty. Is that what you're referring to as emotional contamination? So great question from, I think it's Amy or Army. I'm sorry if I'm mispronouncing that. Justin, do you want to fill this one, or I can take it if you prefer? We're
Yeah,
being like so polite and respectful with one another.
Exactly. So yeah, a lot of different things. So just right, some will call it not just right. This is a great example where we want to do this functional analysis. What is behind that? So you mentioned just right, and again, there's maybe a misnomer, and I am so sorry that this even exists to those of you that suffer with OCD, but there's CLO-CD, right? Khloe Kardashian organizes her things in a certain way, puts things together, and it's CLO-OCD, one of the just terrible examples of misusing the term OCD and I think minimizing those who suffer. And so when we say just right, a lot of times folks will really hijack that and say, oh, it's, feeling a certain way with order or organization, which it can be. And obviously in OCD, it's going to be disabling at some level. It's going to cause disorder. But then I see that you had given the example of feeling dirty. That is an excellent example how just right, it could be easy to say, oh, that's a perfectionism thing. That's an incompleteness thing. But then the feeling dirty, oh, well, wait a second. Sometimes you get this contamination piece and sometimes you get both, very, very interestingly. Or sometimes it's just one or the other and it just takes a specific form. So when we say functional analysis or assessment, what we're doing as clinicians specifically, we're looking at those pieces as they connect together and hopefully training our clients to do this in their own lives as well, to say, okay, what's behind this? What's the trigger to me thinking a certain way and behaving a certain way? What ends up happening? And so this isn't necessarily just right, or feeling dirty and just right isn't necessarily emotional contamination, but it could cross over. So let me separate this into two things. I guess here in a moment we can get into emotional contamination, but first and foremost, as far as the helpful tools, I mean, some of the biggest things that I've found that have been revolutionary have been this concept of functional analysis / assessment, understanding the parts as they work together. So let me give you an example. If we're saying that, so the just right with feeling dirty. Every human on the face of this planet has experienced at some level a moments where maybe they don't look at their hands and they look dirty, but maybe they've gone out in public, maybe they were outside working in the yard or something, and they might not see dirty hands, but they may just feel that. That's a normative thought, normative experience. But in OCD, those alarm bells are going to be going off for a person that suffers with this theme, and it's going to start to disable them at some level. And so when we look at it, we're going to really want to understand for the individual, how is this maintained? What's actually driving this? And so functional assessment could say, okay, well, tell me about the context that this comes up. Well, anytime I step outside my house, like immediately, I notice when I'm outside of the front door, it's like my hands feel dirty. Okay, interesting. Do you feel it inside? No, don't really feel it inside. Okay, so it has to do with being outside of the house. Okay, got you. What if you're at someone else's home? Well, only if it's people that aren't in my family. Okay, gotcha. So we're getting a little bit more information about it. And we don't have to spend tons of time there, but just enough to really gain some basic data on how this thing functions. And then what are your thoughts about that? Well, the air may contaminate my hands by stepping outdoors if I'm not in a safe place or a safe zone. Okay, gotcha. So you believe that in these moments where you're stepping outside of your house or your family's house, that your hands not only feel dirty, but maybe they're getting dirty, contaminated at some level. Okay, then what do you do? Well, I avoid going other places. I avoid going to the public. places outside of my house or family's house. Okay, gotcha. So you've got some behaviors. Anything else you do? Well, I ruminate. If I've got to leave the house, spending a lot of time checking in my mind my procedures for getting outside of the house. And so the functional assessment, it's breaking it down. And in this, just by rough example, the core fear conceptualization may come back to if I step outside of the house, it's not going to be safe. Maybe I'll get contaminated. And if it's based on the feeling, it could just be, I'm just going to feel anxious until I have to wash. And I'm just always going to feel anxious, or it's going to overwhelm me. If it's germ contamination, it could be that I get sick, etc. And the individual variation being so important here, how we structure the exercises and the exposures is going to be based on this information. So that's probably one of the most helpful things that I've found in the specialization of treating OCD. Did you have any thoughts on that, Saharah, before we talk about emotional contamination?
No, I think that's a good point to touch base on for a lot of people, just as we're talking about being able to know that we're not just trying to like shoot darts in the dark here. We really want to get a sense of what are we going at when we are going at the OCD fear? Where are we going? If we're, I use the example of, if we're going on the scavenger hunt and looking for opportunities to really find OCD and sort of take it on the offense, like what are we trying to target? And we need to do that through that functional analysis to begin with. And so I think we were going to try to answer the question. I think we were talking about just right, which I think you were able to touch base on, but also sort of differentiating between what is like traditional when we think of like dirt, germ, illness contamination and emotional contamination. A lot of people haven't really heard about that concept before. And it can present as traditional contamination, but a lot of times it can be this negative association with a person, place, or thing. That thing becomes contaminated, that person can become contaminated just by sort of association with something. I've had individuals in the past who maybe were bullied in junior high school. And so that school, that building itself becomes a contaminated place, or anything or people that were there associated with it become contaminated by association. And so just right can definitely attach to that, right? So whatever the compulsion might be to neutralize or counteract, whether it's washing or saying a certain thing, whatever the compulsion response is to try to neutralize the discomfort, it can be done in a just right way. I have to keep doing it until it feels right. And really it's not wanting that not right feeling, which it can definitely have that tie to emotional contamination.
Yeah, that's right. One thing too, Saharah, could you comment on transformational, for example? So it's not specifically mentioned, so far as I know, in the research as a specific subset. I tend to kind of link it with emotional contamination, but there might be value in separating it. What is the transformational OCD?
Yeah, absolutely. And so, yeah, we do see a lot of connection with the emotional contamination subtype, but basically that could be that either I don't want to get the essence of someone else, which we see in emotional contamination, because maybe that will somehow transform or change me, my person, who I am. I've had individuals who maybe will see it as like a less desirable trait. That's not always the case, but it could be, for instance, that I maybe deem someone as being maybe less intelligent, or I might lose my intelligence. They're kind of siphoning it off of me. And that's where we can see a little bit more of that magical thinking happening, or there could be a little bit less insight happening, and that which can be a little bit of a challenge. Not always the case, but sometimes. But the transformational, where we definitely see a lot of the just right, because it could be like tapping. Let's say, for instance, I feel like I don't want to come into contact with you, Justin, because maybe some of your essence as a man will rub off on me, and I want to make sure that I stay female. And so then maybe it's tapping you in a just right way to make sure that I'm somehow neutralizing that experience.
Great. Yeah, good examples in related to tapping. There can be a number of compulsive behaviors, and even the intrusive obsessive thoughts, they can seem to have a lot of meaning. And so oftentimes that's where we see less insight come up. So a lot of meaning in the religious realm and the scrupulous realm and the relational realm, but then sometimes it can seem to be just noise, such like a song getting stuck in a person's head, where it can be a sound, it can be a word, it can be a number. Like, why won't this number leave my brain? Just it's sticking around. And so even with just like tapping, for example, there can be the range of complete insight to be like, I feel so embarrassed. I know it's silly, but Saharah has to tap on the screen to get a sense of she's complete, getting rid of some sort of essence that she doesn't want. And then it can range to complete lack of insight in those situations, to thinking that, no, this is a principle that I need to follow, I have to follow to actually be okay. So really a lot of variation. I loved, Saharah, how you had pointed out that no individual case is the same.
Which I think that's why when you say you fall in love with this, we as treaters it keeps us on our toes, but also I say that we're a little selfish in that we like to see that change happen quickly, and we know that there's evidence-based treatment to really be able to you know, help people get back to life they want to live. We have a couple more questions here in the chat room, and so one of them is, I've been in a relationship with a woman for about 4 months, and while she's outwardly affectionate, I worry that when she doesn't show any for hours or days, that something may be wrong, and I'll seek reassurance and ask her if something is wrong. Do you want to fill that one for us, Justin?
Yeah, I would love to. So relational themes, very, very passionate about it. Before I specialized in OCD, did a lot of training, Gottman training, etc., to really dig into the side of healthy relationships. But then coming up in OCD, of course, when a person has OCD, regardless of whether a relationship is healthy or not, there will be obsessions when it follows that theme. So just as a reminder, we'll say this at the end. Of course, this is a discussion today. We may be providers, but this is not treatment. And so any person here today, make sure to seek out a treatment provider who's qualified to treat you. We're speaking educationally about these things. So with the question itself, let's say if it is OCD, so it's diagnosed as a subset of OCD, the relational themes can take a number of approaches. Of course, as we've talked about, a lot of variability with it. And I see that the worry is that something may be wrong. So I'll seek reassurance and ask her if something is wrong. And first of all, thank you for your vulnerability and openness. I'm really, really touched by that here to share this, all of you that have shared these questions. So in the therapy process, hopefully we'll want to have a little bit more understanding of, okay, what's bad about that, what's bad about that. We'll use what's called the downward arrow technique to get down to the bottom of the core fear. Not that we have to spend too much time with that. We're looking for the face value, just as far as you know today. And does this fear come out of, excuse me, the fear of loss of relationship, the fear that you'll make a wrong decision, the fear that you'll never be happy, the fear that you're always going to be anxious in relationship. Again, the treatments, if this is OCD, would have to hinge based on those things. And so let's just take one of those, for example. If it is something maybe wrong, and let's take a common one, it doesn't have to be this, but maybe the relationship won't work out right. Okay, well, what's fearful about that? Well, I should have caught it. Maybe I'll be in a relationship too long and then I'll have to have a hard conversation and break up at a later point. I could have saved us some heartache. Okay. So the core fear is that you're going to cause and experience unnecessary suffering. Oh, wait, there's more. I think maybe spiritually I missed out on listening to what God seemed to indicate. Maybe I feel like God gave me a sense a long time ago that this wasn't a good, oh, okay, well, again, this is where we track specifically what a person's thoughts and belief patterns follow with that. And it can cross over into any number of camps specifically. And so the treatment is pretty simple in the sense that I typically say, and I'm curious about your feedback on this, Saharah, we're only doing one thing with OCD treatment, always only doing one thing. Now, it's tricky to do this one thing. We're trying to minimize and over time get rid of all compulsions. That's it. But it's not simple. And so reassurance seeking, yes, like I need this reassurance to make sure homeostasis exists. Everything is good to go, we're clear. But what problems does that create? What disability does that create? So when I work with clients with this as a theme, it's going to be, well, gosh, my significant other is really upset with me. Like I'm asking really regularly, or causes a lot of tension, or I feel embarrassed, ashamed. Like I think on paper it's probably okay, but I just can't feel it. So I have to get that reassurance. And so we're going to not piecemeal, but step by step, sequentially, start knocking out all the compulsions. First to the level that someone can handle and tolerate. We typically put this on a hierarchy of things, and then really building from there. And once they develop the strength, the confidence, the willingness, the readiness to address all of their compulsions, then that's when they start to actually block the level of disability that OCD causes.
Yeah, good point. And to kind of add on to that too, a lot of people feel like, but I have so many things going on. There's so many fears and triggers and compulsions. How will I ever be able to, create a plan on, how to address each of them in my ERP plan? And what I talk to people about is, we've got this list of things, but we aren't going to have to create a specific ERP plan for every single thing.
Mm-hmm.
You start to build confidence and momentum, and things do start to generalize. You get a sense of, and what we want people to do is not to stay in therapy for the rest of their lives, but really internalize this process and become their own behavior therapist, to know basically when I have a trigger, when I'm feeling afraid, the response is the opposite of my OCD is telling me. Instead of retreating, I need to approach. And so when we are able to, and it's not as easy said as it's not as easy done as it is to say it, but as you have more experience and build that sense of mastery in it, you do get a better sense of, oh, okay, this is maybe what my therapist would tell me to do, and create your own exposure plans.
Yeah.
And so did you have anything else to add on to that one? I didn't want to cut you off, Justin.
Oh, no. I mean, there's always more to add. To talk about these themes for the rest of the day and then more, but
I think it was a good segue. We have another question about, it looks like it's maybe from a provider, but how can we support clients in generalizing their ERP tools to identify obsessive loops that don't necessarily fit into their main OCD themes? For instance, someone with harm OCD who's also getting stuck in obsessive loops around making decisions and struggling to notice how thoughts are functioning. So generalizing their ERP tools to identify. Sorry, I just want to read that one over again to make sure I'm not missing anything.
Yeah, and while you're reading that too, in the research literature and then also anecdotally, doubt and decision-making play significant roles in the life of the sufferer who has OCD. So maybe it's according to one theme, but maybe it's broader across the board. So definitely, for example, some clients that wrestle with contamination OCD or relationship OCD or some of the existential or religious sexual themes, pedophile OCD, etc. And they may also report lockup in day-to-day decisions that may not have anything to do with that so far as we know. What's that about? Well, they can't answer that necessarily without more information. And second of all, there's probably a bit of mystery and uncertainty that we have to tolerate as providers too, that we're still looking and trying to understand these things. But when we study OCD, we discover that doubt has such a prominent role. And so even if the person has obsessions on, oh my goodness, what if I'm a pedophile? I drove by a park and I looked and I saw a 10-year-old child and I thought that they looked cute. And then I thought, oh my goodness, what's wrong? And I must be perverted. I'm sick. I need to go away, go home, close myself off, not be around kids. That's a pretty classic P-OCD theme. But that person may also really wrestle with taking classes, which classes to choose, like where do I work, things like that, without necessarily even tons of other indicators of just right OCD or perfectionistic type traits. And so one of the things that can be remarkably helpful just in the treatment of OCD is getting to the heart of it. And even at times going a bit, we call it transdiagnostic. What are tools and skills that we use, like exposure therapy? It's not just an OCD thing. It's a PTSD thing. It's a social anxiety thing. It's a phobia thing. It's so on and so forth. It's a first-line treatment for, I mean, if it's an anxiety disorder or PTSD or OCD, it's first line. And so what's the heart of exposure? Exposure is systematically facing a feared or disgust-based or any sort of aversive stimulus, while sequentially, systematically reducing and getting rid of all the safety behaviors, all the compulsions, etc. And so if we look at it a bit more broadly, this helps when folks are struggling with trying to identify obsessions and OCD. Is this an obsession? I don't even know. Well, we don't even have to figure it out because we can actually lean into the methods that are useful anyway, regardless. It's not helpful to figure out if it's an obsession or not if you're using worry, rumination, checking, compulsions, or safety behaviors to figure that out. And so we can slow it down and look at, all right, where do I want to be? What are the steps to get there? So decision making, I'll say this and then give you a chance to talk, Saharah. With decision making, I don't know, let's say it's trying to choose what your class load is going to be for a semester. Well, is it OCD or not? Even without having to figure that out, we'll probably, we may want to target that as a specific area, but without having to figure that out, you could identify like, okay, where's the problem? Where am I compulsing? What am I safety? Well, I keep on going through it in my head and I keep on changing the class order in my head and have to figure it out. And I think that I'm going to be a failure if I don't get this right, or with the right professor or whatever else. It sounds a bit like OCD as I'm presenting it, but let's say even if it's not, well, so let's target what is the problem here. Well, I'm spending hours in my room at night playing with these. Oh, right away, bam, we've got some things that we can tackle. I also keep calling my parents. I keep calling my friends. Hey, what did you take? Hey, what would you suggest? Bam, we've got some reassurance that we can address, et cetera, et cetera. And so that's how we can start to work even transdiagnostically on some of those things. And then we'll probably discover in time what it actually is. But until we know, we have some great resources and tools to support a person in decision making.
Excellent, excellent. Yeah, or just sort of the situation of when people are obsessing about obsessing, right? Or when I'm not, well, suddenly I'm doing these exposures and I'm sort of becoming a little bit more careless and I should be worrying more about these things. So it can just have a spiral effect in many situations. But I like how you described it. It could be more a function of OCD. It might be more a function of maybe some like worry, generalized anxiety, but maybe the answer really regardless is to act more and to think less. And so the risk is to sort of suspend this urge to try to figure it out and pay attention to it. And so whether it's OCD or more of a worry, that's really kind of the answer with it. And we can use other skills as well, or strategies such as like mindfulness to really be present and in the moment. Notice those thoughts without really going down that rabbit hole to try to figure out the answer, because there's always going to be the but what if. That's always well, most of the times, I won't speak in absolutes, but generally there's that but what if, and that can really drive a lot of that obsessive loop. But what if I don't pay attention to it? But what if something does happen? But what if this is really important? It just feels so risky and I need to pay attention to this for whatever reason. And trying to really just sort of disengage by being present and choosing to live based on values. I'm sure there's plenty of things that are much more important or much more meaningful, rather than trying to answer these unanswerable questions in so many ways. And also, you've probably thought about it from every angle that you could possibly think about it. and trying to really sort of, again, disengage and sort of from the thought and re-engage in the present moment in life. And I like mindfulness for many different reasons, whether it's with depression or with worry, but also using it to accentuate the exposure process. As much as if we go back to sensory motor, I'm never going to stop thinking about this. You're going to stop thinking about it. Our minds are so dynamic. We've got so many things going on. We're thinking about, oh, I'm hungry. What am I going to eat? I got to pay that bill. I've got an exam coming up. There's just all these things that are taking time and attention. And so using mindfulness, particularly for exposures, because that is naturally going to happen, you're going to get distracted, whether that's purposeful or not, but using mindfulness to try to really pay attention to the exposure task at hand and really lean into that uncertainty and think about sort of that feared consequence without trying to push away from it or trying to fix it in some way.
Yeah.
I'm not sure if that completely answered your question. So please feel free to speak up or ask again if there's any follow-up questions about it.
Yeah, a lot of great questions. This is awesome. And if you're just joining now, or if you've been with us the whole time, please type in your questions if you have it. You can also unmute if you prefer to speak, or if you have something that you'd like to clarify or ask further and get information on, just let us know. Wanted to also just stir this pot a little bit of examples that might jog people's memory and or maybe new for some of y'all to hear. So other less talked about themes, or maybe sometimes uncommon if we think of it statistically, but not, if you're working with an OCD specialist, they're not going to be shocked by a whole lot. Obsessional slowness, that's something that comes up, and that's interesting because it kind of pairs with the sensory motor or somatic hyperawareness OCD, but obsessional slowness, a person can get stuck on not just decisions, but it can be as far as walking or moving. Core fear conceptualization is really key in this as well. Is it because of scrupulous reasons that if I, one example that's come up in treatment that I've worked with is if I am angry, then I'm not being open, I'm not being loving towards all. And so people can start checking their facial features. Oh, am I reflecting any sense of anger towards another person? Or, and it can be so debilitating. And what we want to do in that core fear conceptualization is understand, like, okay, what's driving it? Well, you know what? I don't want to sin. Oh, okay. Well, that's different than I want to walk perfectly, or I need to have perfect posture, because if I don't, maybe I'll get an injury and things like that. And so what generally happens with this is that the focus becomes so great, there's a hypervigilance with that, that the process actually starts to get slowed down. So if I think of even talking, if I need to say it right, then I'm going to focus on particular words, versus in speech, we learn to integrate a lot of words together. We have an idea and then kind of words flow out. And so the process in therapy is going to be the flip of that. It's going to be catching, where am I hypervigilant? Where am I checking? Where am I? So on and so forth. And how do I change that so that I can take my life back from OCD? So obsessional slowness, that's one of those less talked about ones.
Absolutely. And it's just to, add on to that again, it can be, you really want to make sure you have a good diagnosis, that functional analysis. For many diagnoses with OCD, it can be misdiagnosed as some form of psychosis, particularly if there is that lower insight. And so if someone with obsessional slowness has difficulty verbalizing what is going on when they're getting stuck in those moments, it could be sort of, from the outsider looking in, kind of seem as like they're catatonic, if it is to that degree of severity. So I think you had touched on it being maybe, whether it's scrupulous and a fear of maybe, offending God in some way. It just, like, everything seems like maybe that's not the right thing. So I'm sort of stuck in indecision. It could be that just right. I'm just waiting until I get that just right feeling. And so I'm stuck. I'm literally stuck here. We talk about stuck in usually metaphorical terms when someone, you know, is stuck in indecision, but with obsessional slowness, they physically are stuck, whether it's until it feels right or if they feel like they've been able to, I guess, appease this sense of, you know, it being sort of, whether it's morally or religiously wrong in some way.
Yeah, that's right. It's been at times discouraging, but I have so much hope, but at times discouraging at how much misdiagnosis exists for different things that come up with OCD, where too many cases somebody ran to a conclusion of, oh my goodness, this is psychosis, or oh my goodness, or whatever. And you know, that also just happens from a lay person standpoint, a family member standpoint. Oh, it must be this. Commonly with children and teens as well, what may appear to be behavioral issues, lashing out, defiance, can be thought of by parents or someone else that's just not looped into the treatment of OCD as, oh, yep, this is oppositional defiant disorder, et cetera. And in reality, I mean, it can co-occur and be comorbid with OCD. But then a lot of times the reality is for children and teens, if they're getting so just beat down and beat up by these things, at some point they can't not just scream out for help or push back at different points. And so those behavioral issues can really be driven out of just fear of any number of things, fear of offending others, fear of offending their spiritual, religious beliefs, et cetera, et cetera. So one little plug too with the International OCD Foundation is that there's so many opportunities to not only be advocated for, but to advocate. Saharah and myself both working with OCD Texas, Saharah on the board, me as an advocate up here in DFW. We're always looking for ways to advocate, and in the Iocdf is having it's called the Virtual Voices for Mental Health, an online day of action. So it's virtual, it's pretty cool. Check it out on the website, iocdf.org. Just one more way to get involved with advocacy, to make others' voices heard, for your voice to be heard. And so really just care for, love on people who suffer with OCD.
Yeah, that's, I had actually heard that one. Thank you for sharing.
Yeah, definitely. Actually, can I guess I can screen share. No,
yeah.
Disabled. Oh. That's okay. We'll figure that out for now. But iocdf.org, pretty straightforward.
Yeah. Does anyone, I know we have a limited amount of time left, and this has been, we've covered quite a lot of ground here. Are there any follow-up questions that we have just in terms of some of the topics we've covered? We've talked a bit about sensory motor OCD, that hyper-awareness into the autonomic body functions. We've talked a little bit about did we talk about existential OCD?
Not much. I mean, reference it by name only, but yeah, I think we can go into that. Yeah.
Okay, so that's actually another one that could be completely missed in terms of seeing it as OCD. I think people will think, well, you're just a thinker, a worrier. You like to sort of philosophize.
Personal crisis.
Right. Yeah. But really, for the individual, this is not about a choice. It feels, again, it's that key feature. It feels disruptive. It feels unwanted. They don't want to think about these things. They don't want to feel so compelled to have to figure it out. But really, that's kind of the function with it. It could be sort of these big life questions about, you know, the nature of mankind and whether or not there is a God, or am I real? Is this really happening right now? Those sorts of questions, and we can all have these questions, just like for the most part anyone can have any number of these other intrusive thoughts. But for the individual with existential OCD, it is repeated, it's recurrent, it's disruptive. It can be really quite disabling, and there's just this need to a lot of researching information and reading about just trying to answer these questions, maybe seeking reassurance from the people around them. There can be a number of different compulsive responses. They might not be overt, it might not be physical researching, there might just be sort of this you know, kind of mental reviewing, checking. I had a client in the past who just felt the need to always be around other people as a sort of reassurance that she existed, and that it wasn't some sort of big sort of fabrication or something that she had made up in her mind that she existed. And so getting her to be able to be sort of on her own without being able to see other people was the exposure.
Mm-hmm. Good. Yeah, that's great. And an important designation that you already touched on with the reference to ego dystonic in the description of OCD is that many times when we get into these existential, some might say philosophical, religious, spiritual considerations, existence, am I real, is this world real, etc., is that there may be actually a lot of valued thought to that person. I've worked with a ton of folks who have gotten or are getting degrees in philosophy, religious studies. I myself graduated from seminary. And though I love to think, I also love to help folks catch problems in their thinking, in their behaving. That's why I love CBT. What's causing an issue, a problem. And so one of the super important things is to separate out, we don't want to spend too much time doing this, but to separate out, okay, what is valued? So a lot of times I will work with folks that it's like, yeah, but I want to ponder on some of these things. I want to think about these things. Well, is it OCD? Because it's not OCD if you like it. Well, unfortunately, it's not that simple in the designation. We diagnose it as OCD when there's those consistent features that Saharah has already touched base on, but you can also simultaneously have things that you enjoy about a topic. And this is where it gets a little confusing with other things like real event OCD, when I obsess on details, particular something that has actually happened. Retroactive jealousy OCD, where a person is obsessing on a partner's past relationships or behaviors, etc. And maybe not as much that one as the real event OCD. A person may say, well, I do want to pause and appreciate this. Maybe it's a loss or a trauma that has occurred for a person, and they also have obsessions about that. They may say, but I want to remember the memory of fill in the blank, a person, a parent, a pet, whatever else. And again, if you get into the specialist realm of treating OCD, and if you are looking for a therapist, make sure you ask them good questions of, hey, have you worked with this? Some of these questions here today, what do you do with that? But we're going to be able to make a separation between what you actually value, but then also the disorder that is starting to take over as well. And we're not going to do it perfectly. We have to work with a certain level of uncertainty in those things. And no matter what, distress has to be tolerated in the ERP process, or learn to be tolerated. Mindfulness, even with suffering and pain, et cetera, et cetera. But just to be clear, sometimes as we call them, egosyntonic things come up. I want to think on this. I want to pursue this information, but then also a piece where, but I don't want to think on this. Just to clarify. Hopefully, I hope that made sense, Saharah, coming out of my mouth.
Absolutely, no.
Okay, good.
I think that has. So, well, we are coming up on our time here, and so, Justin, I wanted to thank you for joining me today, and for OCD Texas for giving us this opportunity to be able to connect with the community. For all of those who attended and were able to ask questions, we're hoping we were able to answer to the best of our ability the questions that you had. But like we said earlier, during this week, OCD Texas will be hosting several different live discussions and presentations. Tomorrow, which is October 6th at 7 p.m. Central Time, Andrea Alvarez will host a community discussion. And so the same way that you were able to log into our talk today, you'll be able to join her and touch base further on some of these questions that maybe you have that maybe we didn't get to today. I know that we'll have Liz McEville later in the week and several others who will be joining. We are the week before OCD Awareness Week, which is next week. We have our virtual walk on Saturday. So lots and lots of stuff happening. As much as we don't like the pandemic and what's going on, it really has opened up so much to be able to really make all of these really these resources available in the comfort of your home, in your office, in your car, wherever you are. So there's so much to be able to take advantage of right now, just to be able to learn and share and educate yourselves and those around you about what OC is and what it isn't. So thank you all so much. And Justin, I'll give you an opportunity to say something as well.
Oh no, that's great. Just thankful that you all came. A lot of great opportunities this week and next week, both the OCD Texas stuff this week, the walk on Saturday, Iocdf stuff next week. Just a word of encouragement. If you're suffering here today, if you're hearing this as a sufferer, there is hope. And I hope that you'll continue to connect with resources, many that we've talked about here today. And or to reach out to that specialized therapist as well. There is hope, and it's how I can work in this field. I would not stay around. I'd burn out way too quickly if there wasn't. So I'm really grateful that you're here, and we'll see you next time.
Thank you all. I hope you have a great rest of your day.